from our speakers and to talk to you about children's environmental health and environmental health inequalities. So I'll jump right into it because I do have a limited time. Um, so let's talk a little bit about their unique vulnerability to environmental hazards, why children are not just little adults, one size fits all. And to a lot of us, I think this is going to be a lot of common sense. So we can just break it down. So first, children have greater exposures than adults to toxic chemicals on a body weight basis simply because of their physiological differences. So they disproportionately take in more air, food, and water per body weight. They have faster respiratory rates than adults. They take in twice as much air per body weight. They eat more food, drink more water per pound of body weight than adults. They may also have unique food preferences or a picky or less varied diet. So that means they might have a greater risk of ingesting toxic chemicals, pesticides, etc. And they have certain developmental behaviors that may expose them to toxins, like putting things in their mouth on the playground. My brother did that as a baby a lot. And their stature or their height might also be a factor. For example, being closer to the ground means you're potentially closer than adults are to metal vapors. I'm thinking in particular of broken thermometers that used to have mercury in them. That was a hazard, right, for children more than for adults. There are also physiological differences that have to do with their developmental stages. So their organs are developing, their metabolic and immune pathways are immature, they're still developing, and there's a real risk here that it could be interrupted. And there's so many examples that that I think we're familiar with: air pollution and immune system dysregulation, endocrine disruption and hormones, lead poisoning and neurodevelopment. So many unfortunate examples. And given that developmental age, that early those early stages, exposure during childhood gives you more time to develop chronic diseases when later on as an adult. So when you're exposed as a fetus or as an infant, so that kind of lead time, it is kind of significant that you're exposed to these chemicals or toxins in childhood. And this brings me finally to their unique exposures and the timing. Pregnancy, for example, is a very unique window of vulnerability to toxic exposures. It has no counterpart in adult life. There's nothing like it. And we know that the timing of exposure during pregnancy is critical because of these developmental stages. So you do have differences in risk based on timing of pregnancy, based on when you're exposed in pregnancy. And we're still trying to figure that out. A lot of that research on air pollution, for example, is trying to figure out when, what is the most critical time. Um, and finally, children are also exposed differently in different places and different times and length of time during the day. So they're exposed in daycares and schools while commuting or walking to these places, playing outdoors, and so on. So it's a lot. I hope I've given you a good idea of children's general vulnerability, but the real reason we're here today is to discuss why, while all children are vulnerable, some children still face far greater risks and why these inequalities exist. So I like to think about it with the help of this figure because for me, the main driver here is structural racism, structural inequalities, and its many interconnected layers and patterns. So it's a main driver of racial and economic health disparities for all kinds of people, but in particular, maternal and child health. Um, I think of structural racism as a historic and present and persistent system of multiple interconnected things, of laws, policies, practices that still perpetuate inequalities. So it touches almost every aspect of a person's life. I've tried to demonstrate here in the social environment layer that, you see housing, education, banking sector, employment, healthcare, and of course the judicial system, or even on a larger scale, things that we're witnessing today: war, genocide, ecocide, famine. These are all intertwined and they feed into each other, and ultimately they perpetuate these inequalities that we see in the built environment, the environment where we live and go to work, and where children go to school and they go to the park nearby, or the trash on the street, the quality of the tap water in our homes. So how does this give rise to these environmental inequalities? Um, these things that we're exposed to in the environment, they become patterned across social, economic, racial factors, across these systems that govern our lives. A city with poor urban policies or a neglected neighborhood might not have access to healthy food, or might have a school next to a metal recycling facility where children are exposed to toxic metals. It's happened in Houston. I've been there. Or have no accessible parks around, so children can't benefit from going to the park and enjoying the green space. So families living in these deprived areas ultimately are more exposed to often to air pollution, poor housing conditions, limited access to green space, and increasingly higher temperatures. And it makes sense, right, that we're not exposed to one thing at a time. These exposures are often compounded, so the inequality is greater. Um, it's not happening in isolation in areas where there's a lot of deprivation. And I'll end here with this figure of saying, like, a lot of this evidence on structural racism and structural inequalities in health has come from the US naturally, but the evidence from the UK is also compelling. It shows that it is often communities of color that bear this unequal burden of exposure and the unequal health impact, whether it's asthma from air pollution or metal poisoning from in the water, or adverse birth outcomes due to heat exposure. And to illustrate, I think I have a little bit more time, an example of a kind of the structural elements kind of coming together and leading to inequalities. One example is residential segregation, which is a legacy of racist institutional policies in the US. You can see the figure on the right. This is a map from the 30s and 40s where the practice was to redline, mark in red on the map, neighborhoods that are predominantly Black, considering them being more risky or bad for financial investment and mortgage loans. So even though this policy has been discontinued, that kind of discrimination and the very fabric of urban, like in urban history, has had a lasting impact on how that neighborhood will develop, what kind of resources it would have, the quality of the education, healthcare, etc. And it's still a big predictor of disparities, particularly environmental health disparities and in outcomes like asthma or poor birth outcomes. Um, and finally, another example from the US and related to residential segregation, because I want to try to highlight why it ultimately perpetuates inequalities and exposure. This is a study of multiple US cities comparing the tree canopy or tree cover between the different neighborhoods in each of those cities using the grade that I talked about earlier, the different colors. You can see in the legend, A is best, D is hazardous in the red. Um, in all these cities, neighborhoods that were formerly graded as a desirable or safe or best, i.e., those in green, still have a higher tree canopy or tree cover today, decades later, compared to the other neighborhoods, even decades after this policy was discontinued. This is except for Seattle in that second row, because two neighborhoods that were formerly graded as D in red were converted into public parks. So they do have more green space. So, but basically people don't live there anymore. That's a whole other question. But for me, this really illustrates the lasting impact of structural racism and how it perpetuates these inequalities decades later, and ultimately health inequalities, because tree canopy or tree cover is associated with better air quality, noise reduction, cooler temperatures, reduction of greenhouse gases, and so on. So those neighborhoods basically don't have the benefit of this green cover. So it still has an impact on health today that cannot be dismissed. And this is not one study. Multiple studies have actually demonstrated this pattern and connected it to environmental health disparities. I think I'm out of time. I think I've spoken enough, right? Okay. So I'm really looking forward to hearing from our speakers to think about their research on studying inequalities. How do we address this problem? What are some good examples from the UK? And I'm really happy to introduce Dr. Rachel Chung. Dr. Chung is a child development researcher and quantitative epidemiologist at Bourne in Bradford. She leads research projects that examine the influence of COVID-19 on austerity on educational, mental, and physical child development. This is as co-investigator on the DSxHE cohort. Also investigates the health impact of indoor air pollution and housing quality in the Ingenious cohort or Ingenious study, and the effects of the urban environment or exposome on family health as part of the Healthy Urban Places study. Dr. Chung, if you could share your screen, and yeah, you have the floor. Welcome.
Thank you, Mel. Sorry, I didn't realize I was on mute there. Can everyone see my screen? Fabulous, thank you. Right, so hi everyone. As Mel said, I'm Rachel Chung. I'm a Principal Research Fellow in Child Health and Development at Bourne and Bradford. I'd like to thank Rashmi and Bish and Mel for inviting me today. I'm really excited to talk to you all. There's an awful lot to cover, so I've had to be selective about what I'm covering. Um, a little bit of background. I was a medical doctor for a number of years and then did my PhD in infant and child development. I've been working at Bourne and Bradford since 2021 in child health and development more generally. And today I'm going to give you an overview of what Bourne and Bradford is, and then give you an example of some of the research that we're doing in child health equity and environment. So, a little bit of context to start off with, if my slides work. So Bradford is the fifth largest metropolitan district in the UK in terms of population size. We're about the same size as Manchester. We are smaller than Leeds and we are definitely smaller than London, but we're still pretty sizable. We've also got about 32% of our population who are Asian or Asian British. The vast majority of those people have Pakistani heritage. And in terms of social circumstances, over a third of Bradford children are born into households in absolute poverty. In comparison, across England, that's more like 1 in 4 children rather than over 1 in 3. So Bourne and Bradford was largely set up with the recognition that minority ethnic communities, in the medical context at least, they're often in the past have been referred to as hard to reach, but we actually prefer the term seldom heard in Bourne and Bradford, which is more accurate. Despite this, they're at more unique risk of poorer educational and health outcomes. And that risk begins really early on in life. So in 2007, John Wright, who was a respiratory physician turned epidemiologist, set up the Bourne and Bradford cohort. And since then, we've grown to an NHS research institute with over 100 people. The director is Rosie McEachen, and we do a lot of work as well with Kate Pickett at the University of York. And the way that we've sort of managed to evolve is really by uniquely embedding research into everyday lives and then using that research to impact change sort of locally, nationally, but also internationally as well. We try to minimize burden on participants wherever possible. So by that, I mean we use existing systems already. So that's routine data collection with data waves on top of that. Everything that we collect, we run through a series of community research advisory groups to ensure that the community are happy with what it is that we're asking. If they're not happy, we don't ask it. And we also evaluate existing policy changes as well happening within the city. So 2 examples related to environment research are Healthy Homes and Bit Breathes. So Healthy Homes is a project that we set up because a social housing provider in Bradford wanted to retrofit social housing homes. And so we're using our cohort to look at what happens before and after that retrofit relative to air quality and respiratory outcomes. Bit Breathes was secondary to a clean air zone that was set up sort of from a national campaign within the UK and then extended to Bradford. And we'll be looking at how a clean air zone impacts on children's asthmatic outcomes and also some adult health as well. So this is a very broad level overview of our original birth cohort. So this is around the 13,000 families that were recruited 2007 to 2011. We've got data on a very wide variety of different things. And this is the original cohort. We have a further two cohorts. So there's Born and Bradford's Better Start, which is an interventional cohort. So families took part in interventions aged 0 to 4. And then we've also got BIB for All, which is our routine data cohort. We don't collect additional data in that cohort. It's just routine data. At the moment, for the main BIB original cohort, we're collecting information in adolescence. For BIBs, we're collecting information at primary school around the age of 8. So that is a very broad overview of BIB. And we use this data in a series of different projects to look at different things. So I'll give you an example of one of those now. These stickers. So these are just some of the projects that we look at with the environment. So healthy urban places, which Jamal mentioned previously. That's about the urban environment and how that impacts on health more generally. It's very relevant to that lovely diagram that you showed with your different zones. But breathes and healthy homes I've mentioned, and I'm going to talk about Ingenious now. So Ingenious focuses on indoor air pollution. So what we did is we took 300 homes of Born and Bradford children and we monitored them for 2 weeks. And we looked at indoor air quality. And this is largely because a lot of research on air pollution is focused on outdoor air quality. We don't know quite as much about what's happening indoors, despite the fact that we spend something like 50% of our time indoors within the home. So we put in low-cost air gradient sensors into 3 rooms within the homes. And we looked at a number of different air pollutants. The main one I'm going to talk about today is something called particulate matter 2.5, so PM 2.5. So this can be of pretty much any origin. So it could be inorganic matter, it could be organic matter. That 2.5 just really refers to the diameter of the particle. So if you look at that picture, that shows you relative to a human hair, to beach sand, how small those particles really are. Because they're really small, and especially for children who have a faster respiratory rate than adults, when you breathe it in, it essentially gets dispersed all the way through your body system. And what that means is that you end up with immunological, neoplastic, respiratory, cardiovascular, pretty much any condition that you could think of, because it disrupts the typical way that we sort of work with these kinds of things. And in, I think there's, can't remember the exact reference, but it's a paper from 2023. So in 2019, ambient PM2.5 is responsible for something like 8% of registered deaths that year. So it was a very serious air pollutant. Because of that, the World Health Organization issued a guideline that people's indoor air quality shouldn't exceed more than 15 micrograms per cubic meter over a 24-hour period. Indoors, they're not supposed to exceed that more than 3 to 4 times a year, and that's the target goal. So what we did is we used this threshold and looked at how often these households with children were exceeding it over a 2-week period. So in this plot, so this is a box and whisker plot, so your black lines are your median, you've got your interquartile range, your individual data points are these X's here. And on the X, you've got multiple index of multiple deprivation quintiles. So that's a geographical measure of deprivation. On the Y, you've got the mean monitored days and percentages exceeding those thresholds. And what you can see is a pretty clear gradation of deprivation where the most deprived households are exceeding that threshold about half the time, so 7 out of 14 days, and the least deprived about a quarter of that time. And that's only within a 2-week period. When we look at ethnicity, we can also see that families with South Asian families are exceeding that threshold about half the time, as compared to the other and white ethnicities are exceeding it about a third of the time as well. Now we know that it's not as simple as just deprivation and ethnicity. So if I show you this plot, what you can see on the x-axis is time in a 24-hour clock. On the Y, you've got mean hourly average PM 2.5. And on the colours, you've got household size, and you can see a pretty clear sort of separation. So households that have 4 or less people are exceeding it much less than those with 5 or more. And that's largely because the more people in a home, the more PM2.5 you'll be generating, but also resuspending in the air as you move through the household. This sort of shows how complicated this sort of stuff is because for both deprived and South Asian households, we have higher household sizes. So a lot of Asian households have multi-generational living, and this is more cultural than anything else. So it's not as simple as just sort of demarcating it into two different groups. The other really interesting finding was that, so we've got the number of people in the sample here and the percentages here is that most people, so 75% of our sample, were absolutely fine with their air quality. So they felt like their air quality was good, whereas our results suggest that actually indoor air quality is actually pretty bad. So overall, we found in the whole sample, the entire sample was exceeding that threshold about 41% of days. 88% of those homes exceeded it at least once. Remember that you're not supposed to exceed it more than 3 to 4 times in a year, and this is just a 2-week period. We had the highest BM2.5 concentrations in deprived and South Asian households. And what we see this as is sort of an urgent need to tackle indoor air pollution as a health risk factor, particularly in these families, but also for ongoing research, some of which we're doing within the Ingenious study, to sort of unpick these causes of inequitable exposure. So that can be things like fuel poverty, for example. So a lot of the households, we also measured temperature. And we know that people are not heating their homes to thermal comfort levels because of fuel poverty. And if it's a choice between keeping your windows closed when you're cooking to keep yourself warm and ventilating, which is obviously going to be cold, that makes things very, very difficult. We also know there are differences around what you cook and how much you clean and so on and so forth, and we're looking at those as well. In terms of policy action, we think this is largely around national public awareness campaigns. So as I showed you with that previous plot, if people think their air quality is largely pretty okay, they're not going to be ventilating when they're, for example, cooking. And that's a little bit because we've done so much on outdoor air pollution, which we say is really bad. And then we're now telling people actually it's worse in your house, so open up your windows. It's quite confusing messaging. That's something that we really have to think about how to do properly. A large part of that we think will be transition to cleaner cooking technologies. So households that had gas stoves had higher PM2.5 than electric. And better ventilation as well. So households in the UK are really largely geared towards keeping heat in. They're not really geared towards good ventilation. That's especially true of some of the new builds as well. Because these things are sort of infrastructure related, the ideal would be something along the lines of, for example, the lead replacement scheme in the UK, where you can get a grant to essentially replace lead water pipes and things like that. Something similar for cleaner cooking technologies and better ventilation for existing homes would be great. And we think this should really be focused in socioeconomically deprived areas because there is that higher exposure in general. So I think that's me. I don't know if we're doing questions now. Are we doing it at the end?
We'll have a general Q&A with both. We
I'll
could,
just
if you have questions for Dr. Chung, maybe leave them in the chat, and Rashmi or Vish will go through them, and we'll definitely get to them after. Yeah, thank you so much, Dr. Chung. I very, very happy to hear about your work, and I definitely have questions for later. Um, I'd like to introduce Dr. Amy Meisen. Amy is a senior lecturer in geospatial health data science at Swansea University Medical School. Her research focuses on creating longitudinal environmental exposures and linking this data with individual level health data at a population scale, the dream, to produce data-driven evidence for policy and practice. I I think, Amy, if you could check that you're able to share your screen, and then I'll mute myself.
Yeah, I think I'm
Okay,
good.
go ahead. Okay, thank you.
Can we see that first slide?
Yes, all good. Yeah, go
Fab.
ahead, Amy.
Okay, great. So thank you so much, everyone. It's great to be here this afternoon. And yeah, Rachel, love that presentation. So amazing. It'd be great, good to chat more later. Like Rachel said, there's so much to cover. So please do get in touch after this if you'd like to discuss anything more or have any collaboration ideas. Really open to that. So as Amal said, my name's Amy. I'm an environmental epidemiologist based at Swansea University. And I'm interested in modelling people's exposure to the environment And a lot of my work has specifically focused on looking at access and exposure to green space and greenness. And also to add, at Swansea, we host something called the SAIL Data Bank, which is the Secure Anonymised Information Linkage Data Bank. And it's a trusted research environment where we have individual level health, social care, education, demographic data on the Welsh population. So for any point in time over the past 25 years, we have individual level data for about 3.2 million people. So we can do these really large scale population based studies. So this kind of infographic just gives a little bit of is a schematic really of what most of my research, the workflow of most of my research. So myself and my team, will be modeling at an individual level people's exposure to different environmental aspects. And then that data is then anonymized and we link it with individual level health data. I referenced there the SAIL data bank. I'm also going to talk to you about where we've done this in Canada as well and replicated some analysis that we led here in Wales. And then, of course, the thing that underpins all of our research is that we take the evidence to decision makers and put something tangible in their hands that they can then go and action. And I think I would say in the context of green space, I'd say globally that the UK the policy ambition is there to make green space accessible to all. The impact on health is recognised to an extent, but I think the thing that I have come to observe is that where the challenge really comes and the disjoin at the moment, I think for us in the UK, it's this disjoin then between how do we get the evidence from policy into the people who are actually delivering those decisions then. So essentially to town planners, how do we create evidence that they can go and do something with? So getting beyond green space is good for health, but what is it about the green space that is good for health? And Amal talked beautifully about why children are really important because they access green space differently. I always, to be really candid, thinking about how my two young sons benefit from green space is very different to if I'm going to take my grandmother out and those benefits. And that's beginning to emerge in evidence at the moment, that people are beginning to recognise that it's got to be more specific ultimately than just green is good for health. So these are just a little example of some papers that we've published. So I'm really interested in kind of these methodological questions that we have. So I'm a geographer by background. I think I would say as an overall, there's so much heterogeneity in the literature about how do we measure green space? How do we define it? What do we mean by it? I would say that something that I always come back to is thinking about what's the research question that I want to investigate, and what are the mechanistic pathways that are underpinning my hypotheses, because that goes a long way to helping you to define exactly what aspect of green space do you want to measure. Just on the right-hand side there, that we had a commentary published in the Lancet, Child and Adolescent Health, which talked more broadly then about this policy disjoint and where can research really make the maximum impact in specifically to do with adolescent mental health. Great. So I just want to be really specific on a project that is just finishing up. So this is my fellowship that I've just come to the end to. So I'm just writing up the results here, and I was looking at whether exposure to greenness during childhood is associated with a reduced hazard of mood or anxiety disorders during adolescence. So basically, during childhood, is exposure to green space and air pollution, are they important in the context then of teenage mental health? So you can see there the kind of how we define these exposures. So annually we had a continuous address history in Wales of around 200,000 children born between 2000 and 2008. And we essentially followed them through then until the end of adolescence, and looking at whether exposure during childhood and then is it associated with a reduced hazard of anxiety or contact with the healthcare system, basically, for anxiety and depression. And of course, there's all these complexities around diagnoses, attending a GP with symptoms, what treatment are you receiving? So all of these things you need to be considering when you're kind of setting up your study design. And then this summer we're going to be co-producing 3 short videos with young people with lived experience of anxiety and depression to disseminate the findings. So I'm really looking forward to that this summer. And then I should also say, so we focused, all the work was led here at Swansea, and then I spent some time in Toronto with a data linkage centre there, and replicating that work. So what we found, so this is specific for greenness given the title of the talk, but we did also look at air pollution. And I think initially when I saw these results, you think, oh no, green space isn't as important as we thought it was. But I think that's quite a shallow interpretation, and I think that's something that we need to balance all the time as scientists, isn't it? Of reporting either null findings or things that are unsurprising is really important, that we don't hide those away as such, but then also thinking more deeply about, well, what is this showing? So you can see the cohort in Wales. We had almost 200,000 adolescents, following them from 0 to 19, and not surprising that the cohort kind of clusters in the most deprived quintile. So that's kind of seen consistently across lots of different health outcomes. And the majority of Welsh teenagers lived in urban areas, and about almost 10% of our cohort had a first contact with the GP for anxiety or depression. So I think something really interesting, so methodologically interesting here. So in Wales, it's very green. So when we're the way that we defined green space here was a satellite derived measure of greenness called NDVI, which is essentially green reflectance. So green vegetation, you pull that out. And the reason why we chose that, one was because we were replicating in Toronto. So if it's satellite derived, it basically makes it internationally comparable. However, you then have the caveats of, well, how do we actually interpret this? And what is it representing? And it's representing green vegetation, but it can also represent not just area, but also volume. So you could have a higher NDVI value, but that is just actually indicative of that there's more dense vegetation there. It doesn't necessarily mean that it's greater area. So it's really actually very quickly gets very complex then to translate. If you're thinking about that town planner of, right, how do I put something in their hands? It becomes very complex very quickly. I'm just conscious of time, so I'm going to scooch on. So in our Toronto cohort, which was, it's 3 times the size, so we're getting on, well, just over 800,000 teenagers there who we followed. And something I just want to say in that the replication in studies, I think we've got a long way to go from a data perspective, in that it was so challenging. We weren't able to harmonize it to the extent that we were hoping to initially. So there's so many challenges when you're thinking about international comparison, which is really important, because what we often see from a public health point of view is that we see that policies are kind of broadly applied, or global health policies are broadly implemented. And actually, we're humans, there's so much nuance, isn't there? So from a broadly from kind of a northern hemisphere perspective, then the UK and Canada are comparable, and yet there is so much nuance to that, and the people who we're trying to help ultimately, and to build fairer societies. So in the Toronto cohort, and I'm just going to finish off here, you can see that we found some statistically significant associations. So that, oh, sorry, I've just lost my mouse. So you can see that those who were least exposed to greenness, it was not significant, but then because I think that's actually representing a whole host of different things going on, because those who are least exposed to greenness or have the least access are generally more deprived. There'll be other things going on that I think will be driving mental health. But you can see that it does become important then for the quintile 2, 3, and 4. So we're writing up these results at the moment. What I should say is that we found across both cohorts then that air pollution, cumulative exposure to air pollution during childhood was really important. And I think when you then come back to, well, what are these mechanisms that are driving that? Actually, how do you cumulatively collect the benefit of green space? I'm not sure that you do, whereas you do cumulatively receive the detrimental impacts of air pollution when you think about those pollutants remaining in your body. And what we've seen in the Welsh cohort is that we didn't see anything statistically significant through childhood, but actually some of our preliminary findings show that that year preceding an event of mental health is really important. So just to reinforce that issue of, think about what's your research question, what are those mechanisms that are underpinning your hypotheses, and that will really help to define your how you're thinking about how you want to define access to green space or greenness. Just want to finish with, sorry, I've lost my mouse. I'll skip over that one. So this is my team, and these are some of the projects that we've got going on. And just to flag that Dora is writing up some really nice work at the moment where we've linked garden size with childhood BMI, and then also kind of viewable green space and adolescent well-being. So that's some ongoing work that we've got. And I'm going to stop because I've talked for too long. I'm sorry.
No, that was excellent, Amy. Thank you so much. Well, I have questions, but I will open up if I think in the chat if anyone has any questions, or if someone is able to just unmute themselves and ask questions. I'll give you a minute to think. Questions for both Dr. Meisen and Dr. Chung, if there's any. No? Okay. Oh, I can read it out. Kelsey Sennett. Kelsey says, wonderful talks. Dr. Meisen, how do you parse apart access and exposure to green space? Great question. How do you handle SES or socioeconomic status statistically? Do you control for it in your analyses, or run analyses twice, one with, one without? Oh, so we're talking statistical approaches here. Okay. Given it is so intertwined with green space access and motivation for use.
Yeah, great question, Kelsey. I'll try and be as brief as I can because I could probably talk for the rest of the time. But access and exposure, that's, I think when you're coming back to, again, what are you trying to represent in your exposure? So access, we would be looking at kind of the distance to a park, perhaps, or how many parks do you live within 20-minute walk of your home. Your exposure, I think, would be more to do with kind of your ambient, what's around, in the same way that Rachel described kind of outdoor and indoor. So thinking about your outdoor, when you look out of the window, what green space is there? Happy to chat more later. Yes, we do, as kind of a minimum, what we're able to do with the population scale data, as a minimum, we would control for index of multiple deprivation. But what we're doing in some of our studies, when the data is available, we will adjust for individual level deprivation. In that green space project that I just talked about, I was also adjusting for mum's mental health and smoking status within the home. So trying to dig deeper. It's complex, isn't it? And sometimes there is a limit to what we have data on, especially at the population scale. Very jealous, Rachel, of some of those lovely measures that you have. But yeah, I'll stop there, but happy to chat more
Yeah.
offline, Kelsey, if needed.
Great. So while someone is typing, if anyone's interested, I have a question for Dr. Chung. Rachel, I find the Born in Bradford cohort so interesting and compelling. And I mean, this is something I knew before I even moved to the UK. I was like, I need to I got excited, need to get involved in this. But it is a very necessary resource. But I also wonder, um, how generalizable is this in England? And are there other studies that have looked at these inequalities? I mean, in particular with children's inequalities and indoor air housing quality and indoor air quality, have looked at different kinds of among different populations or subpopulations in the UK.
Yeah.
Can you
So
comment on that?
yeah,
Yeah.
of course. So that's sort of two different questions there. So we
Yes.
often
Sorry.
sort of no, that's fine. So we get that question quite a lot. So
Yeah.
is this idea that Bradford is in some
Yeah.
ways some sort of anomaly? I think we often don't ask that question of other places, which I think in itself
Yeah.
may be a little bit telling. I'd say that
True.
it's actually a very good example of what we call like an urban contemporary cohort.
Mm,
So there are lots and lots and lots of post-industrial cities across the
mhm,
north in particular that have quite a similar makeup. So we've got places like
mm,
Birmingham, places like Manchester, places like Leeds, and so on,
mm,
that do have quite a high ethnic density of different populations. They experience the same types of post-industrial
mm,
change that Bradford has experienced, and
mhm.
the subsequent population health as well. I think a lot of the
Right.
studies that have gone previously can sometimes sort of be slightly more South-centric in some cases.
True. Yeah.
So it's also there are lots of different cities across the world where you've got different types of people that say high migrant populations and so on that cluster around urban environments,
Hmm.
where your population age is younger than what you'd find in other places. So we have generally seen this as an exemplar of those types of cities. Your second question was more broadly about
So
relates to other
more for my
studies.
own, just I was curious if there are similar studies being done on indoor air quality
Yeah, so
that looked at inequalities or racial inequalities.
I think less so on inequality specifically in the UK. There's a couple of studies. There's a Wellhome study that I think is in the UK as well. There have been studies across the US on indoor air quality, but again, this is a different type of
Very,
ethnic group, right?
yeah, very
So the
different.
kinds of ethnicities that we see are different. And the thing about indoor air quality, especially, is that it's a lot of what we found is that your quality when you measure inside the home is generated indoors, not outdoors. So the
Hmm.
variation outdoors doesn't change that much, but the variation indoors changes loads, which suggests
Hmm.
that the sources are indoor.
Hmm.
Because they're indoor, that's very specific to individual behavior,
Sure.
which one makes that really hard to study at a population level. And so we've got some broader studies that have larger samples that are trying to look at some of those
Hmm.
things. But it also means you need quite detailed data on the kinds of things that people are cooking, for
Yeah.
example, how often they're cooking, how long they're
Hmm.
cooking for, and so on. And that will also change culturally as well.
Yeah.
Um, so
Yeah,
that, yeah,
very unique. Sorry, I was just saying very uniquely placed in order to, I mean, just as born in Bradford and these other cohorts, very uniquely placed to allow you to examine this research question, which is why I find it fascinating. And it will always be an incredible resource. Yeah, I love those figures. I could talk about them more, but I should probably wrap up and ask if is anyone else have questions? I don't see anything in the chat. So shall we maybe wrap up?
I
Oh,
have
Vish has
question.
her hand
Sorry,
up.
I
Go
can't
ahead,
seem to
Vish.
raise my hand. But thank you, both of you. This was really interesting, and it's actually my first proper exposure to children's environment, so it's truly been inspiring. I have a question for Amy. So I was wondering if there is any aspect of duration in your research about exposure to green space, or is that just something that's not feasible to measure or
Sorry, could
study?
you
And
say that again?
if there is any aspect to like duration to green space exposure, like the exposure to green space, or
Yeah,
if
as in
that's
the
just,
time that you're exposed to.
yeah,
Yeah,
basically.
yeah. I think you've hit the nail on the head there of what, as epidemiologists, we try and pin down of, yeah, what is, how long do you need to be exposed to it to receive the benefits in the context of green space? I don't have an answer for you immediately, but or yeah, I think research is starting to nudge at that. But I guess something that I'm interested in is kind of how we then bring together lots of different data sources of when a project that I'm involved in, we're looking at, oh, well, and Amal is on. So the Magenta project, we are linking lab data, epidemiological data, and then this large scale population data too. So you're able to look at biomarkers and to look at how this project specifically is looking at how pregnant women respond to heat. What are the biological mechanisms there? But we could do that for how do people respond. You could put sensors on people, go into a green space. How is their cortisol reduced or something? And then you can use those mechanisms to inform some of our big data approaches and vice versa. We're seeing this in the big data. What are the biological mechanisms there? What's going on? So I don't have an answer for you, but maybe in the next decade we will.
I will email you again in a decade to ask. Thank
You
you.
should join our team, Fish. You'll have all the answers or more questions. Um, I muted myself. Sorry, everyone. So I think we'll wrap up just because we're getting close to the time, and think people would like to head out. I was asked to remind you that our next session of data science for health equity will be in September, so keep an eye out. And I think this will be posted on the website, right, Vish, Rashmi? So hopefully you can see it there. And yeah, I just wanted to thank our guests again. Thank you all for coming. This has been really fun for me. I love this stuff. I hope it was interesting and helpful. Yeah, thank you all again. Thanks. I think we can exit, right? Okay. All right. Bye, everyone.